Thank you, ma'am, for giving me this opportunity. And now I'll be talking about the manual dissect instead of. So far, we have seen the anterior lamellar. Now we'll see something about the posterior lamellar. And I have no financial interest in any of the instruments or any products I show here. And in equipping ourselves, for manual dissection, you don't need much investment. You need only modest instruments. But what you need is repeated practice with substandard corneas from the eye bank to practice yourself for the lamellar dissection. That's very, very important. And for the instruments, I use this Catena anterior chamber, artificial anterior chamber, which is quite handy. It is supposed to be disposable, but we can use it several times also. And the main important thing, once you lock the tissue, you can just dislodge the thing and you can hold it in one hand and rotate the artificial chamber according to the dissection where you are doing, so that we can maintain the plane of the dissection. And the dissectors, you can use either the steel ones or you can use the disposable ones also. And the donor tissue, again, I pay more attention to not only to the cell count, to the cell morphology, as well as the cause of death or freshness of the tissue, age of the donor. All these things matter when you select a donor button for dissect rather than only the number of endothelial cells. And then coming to preparation of the donor tissue, the mounting on the artificial chamber, the scleral frill should not be too short or too long. It should be exactly fitting, and also you have to remove all the excess episcleral tissue. Then after locking, it should be well centered. It should not leak. And then you check for the leak all around again one more time, and also check the pressure. This pressure should not be too tight or too low. Too tight, you can end up with perforation very easily. A too soft locking, then you can end up with a very thick graft. Then you can make this limbal section first, assess your depth, and go ahead with the dissection. And once you make this limbal section, and you can, when starting, initially we used to use the slightly blunted crescents. Then when you are doing this dissection, you can, if you do it under air interface, as in Mellis technique, we can actually assess the depth for which we have gone already. And if we are comfortable with the depth, then we can proceed with the further dissection. And here, like another clue that we have reached the really posterior stromal lamellae. That posterior stromal lamellae, as you all know, it's parallelly arranged. You can see the ease with which the side movements of the crescent it's going. So with that, we can know that we have reached a proper depth. And then the rest of the dissection we can do with a long blunt dissector. And it's very important to dissect up to the periphery, the limbus. And then while dislodging the tissue, again we have to invert it and dislodge so that it will not dimple and damage the endothelium. And then check that all around it has been separated. Then when using this, you have to remember suddenly there may be a mechanical failure or mechanical leak from the artificial chamber, especially when you used it several times. So always keep one artificial chamber in store, suddenly, when otherwise you may end up with a problem. And at the same way, the leak may be somewhere else also. So that for that also we have to be prepared. In this case, you can see some poke injury occurred during probably the donor preparation. So the air is leaking from that site. So I suture that site. Then you can go ahead with the dissection from the opposite side, and you can finish the dissection. And even while during the dissection, halfway through, if you have a perforation also, as we have seen in DALK, we can try this technique. We can go to the opposite side and try in a slightly superior area level. You can try to finish the dissection. And button insertion you can do in a large 5 mm scleral tunnel or corneal tunnel, as in rigid IOL, or it can be like a foldable IOL. You can use a smaller section also. The technique can be a folded one, or after folding the flap, or you can push it in, or you can pull it through a small section. So the button insertion usually, like before starting the button insertion, after scoring the descemex, you have to wash the anterior chamber of all the viscoelastic. And what I usually used to do, I will inject air and see whether the wound integrity is fine, because I always use a 5 mm or 4.5 mm scleral or corneal section. So if I feel that wound integrity is not good, I pre-place a suture so that it's easy for me after inserting the donor to manipulate. Then, like this is a taco method where the donor has to be folded 60-40, and then we can insert it with the atraumatic forceps. But initially I used to do this, then I feel that it's traumatizing the endothelium more, then now I stopped it. So now my preferred method is the push-in method, where over a viscoelastic glide, that is sodium hyaluronate, I place the donor button with endothelium side down and push it in with the 30 gauge needle so that there is no folding, unfolding here. Simply we can just keep it in there and place it with a air bubble. And another thing, after insertion, what you have to remember, again reform the anterior chamber, deepen the chamber a little bit, and then go and inject a small air bubble first. You can see here the button is slightly thick and it is sliding towards the wound. So it could be because it is a thick button, or it could be because the wound is leaking. So after a small bubble, you try to manipulate it to the center. But still, if you feel that it is sliding again and again, better to suture that wound. And again, while inserting the air, we have to be very, very careful while injecting air. You can see here, if you keep it very superficial, you can inject and dislodge the graft also. So this will again cause more and more endothelial damage. So in all your manipulations, you have to be very careful. So that at the end, to improve the attachment, so we used to fill the anterior chamber completely with air and wait for 10 minutes. Many people used to do either you can use venting incisions to milk it out, milk the fluid out, or you can roughen the stroma, recipient stroma before after scoring. But what I used to do, just apply water-cleared glycerin while waiting for the tissue to adhere. At that time, every 2 minutes I'll apply a drop of glycerin so that the anterior stroma will get desiccated, and that will help a proper attachment. And then we can release the air to a proper level and finish the surgery. So this is a very good, even with the manual dissection, we can get very good uniform, thin grafts. But sometimes you can end up with a thick graft where it can go for a hyperopic shift. But still you will get some interface opacities. But generally these visual rehabilitations are very good in eyes which are not previously violated. But of course in automated dissect, like you will get a better intersurface. Thank you.